I think we're heading towards socialized medicine. If you look at Medicare and Medicaid combined, it's more than half. So in many ways, 30 years ago, we might argue we're at socialized medicine now. But we got it there the hard way and in a way that I think is a patchwork that doesn't provide very good care for primary care.
Welcome to In Our Town, Conversations with Springfieldians Making a Difference. I'm your host, Tom Carlson, publisher of the Springfield Daily Citizen. If you'd like to comment on this episode, our email is inourtown@sgfcitizen.org. We'd love to hear from you. My guest today is Steve Edwards, the former CEO of Cox Health. Steve worked at Cox for 30 years, the last 10 years as its president and CEO. Since retiring, his services as a consultant have been in demand. During the COVID pandemic, he received especially high marks for his leadership through that crisis. Today, he joins us to talk about the state of healthcare in the United States, what we're doing right and what we're doing wrong, and why is healthcare so expensive in the United States compared to other rich countries. Steve, welcome to In Our Town.
Thanks, Tom. Honored to be here. And I'm always going to call you mayor because you're my mayor. I became politically activated in college, and you were our mayor and our longest serving mayor. So it's an honor.
Well, thank you. I did a little research, Steve, before the interview today, and according to what I found, it said the United States spends about 18% of its GDP on healthcare, and that's almost twice what other countries spend. It said that in the United States, we spend about $13,000 per person, $5,000 more than any other rich nation, and our outcomes aren't much better. What's going on?
Yeah, I mean, you're right. We're 18.2% of our gross domestic product. If you look at most of Europe's around 11%. United Kingdom, which probably is most similar to us culturally, is at 11%. And you're right. At the same time, UNESCO ranks us in like the bottom below 100 in outcomes. And so we're paying a lot. Our outcomes look bad. But then here's the contrast. In almost every major city in the United States, there's a hospital that's as good or better than the best in the rest of the world. So what's going on? And what I would argue is we have the most unhealthy patients. And here's how I would argue that. In 1975, about 2% of our population had diabetes. That number started to grow. It's now 11%.
Five times.
5 times in a very short period of time. And it was a stable, actually, since we found insulin as a therapeutic, the percentage of diabetic had been stable from 1940 to 1975. We have enormously higher rates of what I call metabolic diseases or syndromes. So that's hypertension, it's stroke, it's heart disease, it's diabetes. And so what's driving that? And I'll argue we're unique. Most countries aren't combating that. But as our culture goes into new countries or they start adopting our culture, they begin to get the same issues. So,
well, to your point, for 10 years, my wife and I would vacation in Mexico.
Mm-hmm.
And the people in general were always very trim. But in the last few years, I've noticed more obesity.
Yeah. I mean, so if you look at it, in 1975, a Japanese scientist perfected the formula for high fructose corn syrup. And we began to replace that in our food. It's cheaper, it's more flavorful. And so instead of reducing the amount and saving money, we put as much or more in. And now if you look, corn syrup, high fructose corn syrup is in almost every food we eat. Anything in a box, even bread. Foods that were once staples now have the sugar content of what were desserts before 1975. So our diet is driving metabolic diseases. I think right now in any hospital in the country, probably 80+% of the patients that are in the hospital are suffering from metabolic disease. And if you look at those numbers in other countries, much lower. And if you took that out of our system, I believe our percentage of GDP would be about the same as Europe. So it's really driving costs in our healthcare system. And, the reality is we've improved the longevity of life. But if you look at the last 30 years of life, we've not improved the quality of life. People are suffering from comorbidities and many, so we're not really having a wonderful life.
Well, let me ask you that. How would you trade that off? Are you suggesting that the government should ban corn syrup?
Well, I don't think you can morally change culture with legislation.
Okay.
I mean, you've got to change culture. But I will tell you that, as I left Cox Health during the middle of a pandemic, or at the end of a pandemic, now it's endemic phase, I began to reflect and realize that my whole career has been in a pandemic, a metabolic pandemic. I saw in my career the life expectancies in the United States finally start to go down. We've seen this huge increase. And so what I think it is, it's, there's three things Americans are really struggling with is we don't exercise enough. We take in way too much processed food, which hurts our liver. And then we take in way too much sugar. And so if you just eat foods on the outside of the grocery store, right, you eat the vegetables and stay away from things in boxes, we will lose weight. If you restrict your carb intake, we'll lose weight and be healthier.
As an industry professional, somebody that's thought a lot about this for quite a while, how do you get people to change their habits?
Yeah, what we find out is there's a lot of people that are shaming people who have weight issues. And the reality is many people don't have a choice. Their access to food. So, we've heard of the phrase food deserts. We also have food swamps. We have areas where the quality of food, the cost of food is so unattainable. So what can we do? Ironically, one of the things that has driven this has been subsidies for corn. A very small percentage of corn is really used to eat as corn. It's mostly turned into fuel and into corn syrup. And so our policies led toward that way back when we started subsidizing corn production. And I'm supportive of farmers, right?
Right.
But at the same time, we produce way too much corn and we turn it into corn syrup. And then we make every food taste a little bit better for all of us. So, years ago, the United Kingdom changed the ability for a manufacturer on how much salt they can put in food. And when they did that, they saw hypertension go down and heart attacks go down. Because they control the cost of their healthcare system, since it's a national system, they did that and it saved the country money. So you can legislate that, but I have found in the United States, we're not big fans of the government intervening too much.
Right.
I've learned that lately. And
Mark Twain says there's no lesson in getting kicked twice by a mule.
Correct. Correct. I agree. Good Missourian.
Yeah.
So, you can try to legislate change, but I think it has to be informed, trying to encourage people to eat better by helping identify. So we can begin to say how much corn syrup's in our food and let people see that and make choices.
So maybe I'm just wrong in my impression. I thought that the United States, just our general cost of delivery were higher than in other first world countries. But what I'm hearing you say, we're just a sicker nation.
I mean, in many ways. So we've made huge strides in treating heart disease, stents, and, any kind of intervention. So less people are dying of heart attacks, but more people are having them. And so what's happening is we're spending our dollars in the acute intervention. We're spending it at the tail end of care. I once had the opportunity to meet the head of the Southern District of Norway's healthcare system, and he had the budget for the entire healthcare system because it was a socialized system. I'm not an advocate for that, but at the same time, he knew that he could take those dollars they're spending on acute cardiac interventions and do more childhood preventative care and save the country money. And those countries who have done that, like Norway's 11%, that saves money. So we do spend way too much money on the end stages of life. And also we're kind of spending it on what's, for many people, a brutal last 5 years of their life. It can be very brutal.
I've heard that the incentives are not aligned well. Again, it seems to me that, I think it was World War II? There were wage and price controls.
Right.
And so the way that some companies got around that and went ahead and gave essentially raises to their employees was by providing them health insurance. And so as a consequence of that, people didn't really care what it costs because your employer's paying for it. Has that resulted in, I guess I would call them misalignments and skewing the incentives?
Yeah, I mean, it's aligned to get exactly what we're getting. I had a professor in graduate school, an economics professor, and in organizational behavior, and he said, okay, how many have heard about Herzberg's theory? And we raised hands, and Theory X, and William Mucci. And he erased it all and then drew a dollar sign. And he said, follow this. And, the incentives are causing utilization. If you're a physician and you get paid to do a certain procedure more than another, and maybe you were sued once for not doing it, so you're more likely to do it. So our incentives are getting us exactly what they're designed to do, high utilization at the last stages of life.
Well, I think it was your dad. I knew your dad, Charles. And I think he said to me one time, gee whiz, this is probably 25, 30 years ago. He said, doctors are paid to do procedures, not to think.
And that's what a good internist would tell you. One of my mentors, Dr. Lauren Broadus, who's an internist, he said, we're not paid anymore to think. Sometimes the best medicine is to let someone go through a process and let their body, kind of naturally take it on. So the government put in a new system in the late 80s, and it paid doctors based on procedures. And procedures went up. And thinking professions like internist and neurologist got paid essentially less. And then when you come out of medical school with a $400,000 debt and you're debating which specialty to get into, you go into the one that pays the most. And it makes common sense to me. So then you go into the ones that do more procedures. So yeah,
Right.
Our system's driven us to this point.
Is this true? Somebody told me it had to do with some kind of device that they use for people for hips or maybe in their spine. And there was the company that sold it would only sell it to the hospital if the hospital agreed that they would not disclose what the thing costs, so that there was no way for Cox to know what Mercy or Barnes is paying for a device.
Yeah, I mean, years ago, they did sign confidentiality agreements, and we saw wide variability in cost. The industry responded to that by creating buying groups. Under the buying group umbrella, you could share that cost information, and we began to see that this academic center is paying half of what this community hospital is paying. Then you'd ask, well, why is an academic center paying half? Well, because they're training these doctors on that, so when they go to their new place, they want to use that technology, that procedure. So it's an investment. It's kind of like giving someone baby formula in the hospital, knowing they'll probably keep using that formula when they leave the hospital for their baby.
Okay. Well, still, I'm the poster child for somebody who could probably improve on his diet,
We all could.
Exercise. But the costs of healthcare are going up, and particularly, as you noted, end-of-life care. I don't know, the number I've heard is 40% of the healthcare dollar is spent on taking care of people in the last few months of their lives, something like that.
I hear those numbers, yeah.
And I don't think it can go on forever. So why don't the politicians address the issue?
I think as more and more of our federal government is consumed by expenditures for healthcare, and we have to begin to make tough decisions, I think they'll begin to wake up to that. You and I can talk politics for weeks, but the problem is we have very short terms. And so most politicians are running to keep their job. And so any plan that needs a solution that's going to take 10 years, and you've only got a 2-year term in Congress or a 4-year term as president, you're not as worried about that, right? So I think part of our structure doesn't allow us to look long term. These other Western countries that have the responsibility to care for the cost of their whole country, they can invest in long-term solutions. So I think that's a challenge, but ultimately we've been saved throughout the last 2 centuries by our innovation and our technology. We keep finding great new solutions. And we are the driver of, innovation. There are more patents in pharmaceutical and technology coming out of the United States than the rest of the world combined. So there are great assets to our system. Mm-hmm. And we're kind of driving that, but it's very, very expensive.
But nobody will talk about it. Just as you mentioned, they don't want to talk about Social Security.
Right.
They don't want to talk about Medicare.
Kick the can down the road.
Kick the can down the road. Aren't we seeing here in Missouri the closing of a lot of rural hospitals? I mean, what's causing that?
Yeah, so we've lost 5 or 6 rural hospitals in the last 10 years. One factor was Missouri's Medicaid reimbursement is extremely low, one of the lowest in the country.
Didn't we change the Medicaid law a couple of years ago?
So a good thing happened that we expanded the coverage of Medicaid, so more people are covered. And from a hospital perspective, what that means is there are more people that have insurance that only pays a fraction of your bill. So it's maybe better than no insurance. But, here's an example. For the Springfield hospitals, Medicaid reimburses a hospital about $700 a day of care. We have medicines that may cost $20,000. And so you don't get any reimbursement for that. You get $700. So Medicaid is funded at a very low rate. See, it's a federal state program, and each state can contribute their own amount, so they can kind of set what the reimbursement rate is. So Missouri is very low. Maybe California or even Kansas pays much better. So that's a problem. It's also this challenge why we're seeing more people move to the big cities, right? There's more opportunity for many. And so we're seeing population demographics declining in rural areas. And as it declines, the need for hospitals go down. So you're seeing the demand shift toward the metropolitan areas. What also means is if you're living in a rural area and you have a heart attack, you might be an hour away from a hospital.
Steve, if you were king, how would you fix it?
Well, I think we've we've got to be focused on moving our resources from acute intervention toward prevention. So I'll give you an example. You mentioned consulting. I'm helping an IT startup company, a healthcare startup company. They've got a series of protocols for patients with metabolic disease, and they've had 3,000 patients on this protocol. And as a result, the average A1C is down 11% for these patients. Their weight is down 8%. And there's a concerning thing called non-alcoholic fatty liver disease. The result of that means you need a liver transplant, and in worst case scenario, those are $1 million. And they've lowered those numbers by 10 to 15%. So they've got a physician-driven protocol with education, incentives, and feedback for patients. And, I think programs like that, so we call those digital therapeutics. So
is that the same thing as the reimbursement process for some place like Mayo, where they pay you according to outcomes rather than the amount of procedures? So is that what you're talking about?
No, a little different, but that's another way to try to align incentives. So Medicare are starting to pay physicians and hospitals based on outcomes. Mm-hmm. It's being kind of eased in over time. The biggest way to disrupt the financing of healthcare in the United States is absolutely broken. I will argue we have the highest quality acute care in the world and some of the lowest quality prevention and public health because we don't spend much money on it. But I think the most dramatic way to do that is to give a healthcare system a lump sum and say, take care of this patient. And if you do that, because right now for most hospitals, they're not incented to avoid a heart attack. They get paid when someone has a heart attack. That's really perverse incentive. Their mission and their motive keeps them from, still fighting heart disease. But if you put the money and say, hey, you've got a bucket of money, here's your Medicare spend, and we'd like you to focus on whatever way helps you financially, we'll start focusing more on prevention. Just think of if pneumonia, very high risk of death, and we have vaccines for it, we're going to reduce that. It's worth investing in that vaccine versus, ventilator care, for example. So I think that's one way to disrupt it is make sure that the healthcare system's responsible for the whole dollar of care.
We'll be right back after this short break.
Hi, I'm Rance Berger. I'm the managing editor of the Springfield Daily Citizen. I've been a Missouri journalist for about 18 years now. I've worked a total of 8 different jobs in 5 different places, but it's all been in Missouri. The hardest part of my job is really finding time to give all of our stories the love that they deserve. We have such a great group of reporters. When they work that hard, I want to be able to put that much work back into their stories to make them even better. The most rewarding part of my job is just being as plugged into what life is here in Springfield, Missouri. I get to know everything that's going on in government, in business, in education. I like living in Springfield because it's never boring, there's always something to do, and there's a wide variety of experiences available. You just have to be willing to put yourself out there a little bit and go look for them.
It seems to me, as an outsider looking in and pretty uninformed on specifics, that there's sort of an arms race here between different hospitals. For example, if Mercy gets the latest MRI machine, there's got to be pressure on Cox Health to have one too. Mm-hmm. And then, I don't know what the darn things cost. What would one cost, for example?
$1 to $2 million, depending on the...
Okay. Well, you got to pay for the darn thing.
Right.
And so there are going to be perverse incentives to send people for those kind of MRIs because you got to pay for it. Why doesn't the government come in and say, Cox Health, Mercy in Springfield, whomever it might be, here is $300 million, and that's all you're getting.
Yeah.
And so you're going to have to pass on some of the fancy stuff and just be more focused on the overall delivery of healthcare.
Yeah, I think that's where we're headed. And the government has already articulated designs to go that direction. In my tenure as CEO, there was a movement for hospitals to try to get their costs down to the Medicare reimbursement rate. Medicare reimbursement rate varies across the country. It's very low in Southwest Missouri because it's sort of based on an index of wages. Mm. So we looked at the numbers, and I came to the conclusion that if we lower it to the Medicare rate, we will undermine the quality of care. We'd have to have less nurses, and there's a point where you have less nurses, quality of care goes down, and costs go up. And so we decide we must take a different track, and that's when we decide to invest in insurance companies to take on that risk. So we create a Medicare Advantage plan. So essentially, Medicare gives us $1, and then we work with our physicians to help manage that dollar better and toward prevention. So while not all of our care is that way, probably 30% of the care we provide is under that kind of umbrella of risk. I think that's the right answer.
Is it going to come into being in my lifetime? And I'm a reasonably healthy old guy.
I'm looking at you, and I think you got a good 60 years. So, yes. Yeah, you're asking me to answer questions I don't know about your health history. But, United States, we don't do things radical overnight. We ease them. Most of our government policy programs are woven in, right? And so we're weaving it in right now. So our Cox Health plans has kind of carved out the profit from insurance companies. So it's a not-for-profit. And so if someone gets care into Cox Health plans, there's not a big share going to fund Wall Street investors. It's staying back in that fund. And that dollar is 100% at risk. So if you get insurance through Cox Health plans, you're paying a premium. That's all the money they have to work with. So they're incented to lower their costs. Our primary care docs have a big portion of their salary linked to things like managing hypertension. So if you have a patient that has hypertension, you're not managing it, that hurts your score. If you're managing their hypertension, you get it down below 120, 120/80, whatever that metric may be, then it helps your score and you get better reimbursement from our own insurance company. So we're going that way. And I think, yes, in your lifetime, you certainly have that choice right now under some Medicare Advantage plans.
You talked about earlier that if you are graduated from medical school, it's not unusual to have $400,000 in debt. So you got to pay it back. If you're a specialist, particularly somebody who do procedures, you probably on balance have a higher income than the internist that gets whatever an internist gets for an office visit.
Right.
My sense is there are a shortage of primary care doctors and nurses aid. Is that true?
Yeah. I mean, there's a shortage of almost every segment of healthcare providers. As our population ages, we're both aging, which demands more healthcare, and we're losing people from the workforce. So you've got that issue to start with. But more importantly is if you want to be a pediatrician and maybe your starting salaries, maybe after 5 years in practice, your salary is $180,000, or you could be an ophthalmologist and you make $1.5 million. And by the way, you don't have to go to the ER. By the way, you don't get called in the hospital. By the way, you can only work, do 2 OR days a week and then see patients. Which direction do you choose? And I don't blame physicians who are burdened with $400,000 of debt and making those choices, let alone the lifestyle choices, because it's really hard to be a primary care physician. I would argue they're the hardest working physicians on our medical staff now.
Again, if you got to pull the levers, what would you do to fill that gap?
Yeah, you got to follow the money. And so one is you've got to put more at stake for primary care doctors. So as you look at health plans and how you employ doctors and incent them, if they are the ones who control the most cost, give them an advantage in controlling that cost and give them incentives to do that. So that's one thing. The other is we don't fund graduate medical education at the level that we could. So for example, right now there are more people graduating from medical school because we've expanded medical schools than there are residency slots. So residency is very expensive to train. The federal government helps reimburse for that. And so they've not expanded those slots in a long time. And actually Governor Parson and others are pushing a bill to do that. So we need more of that. So if you expand primary care slots, then you have more medical school students choosing primary care. And ultimately, you know how the economics work. If there's a shortage, that shortage will make that position more valuable and it'll balance out. But right now, the shortage is particularly acute in primary care.
Well, why aren't we educating more physicians, assistants, and nurse practitioners?
Yeah, I mean, that's what's happening. Drury just started a program. They have 31 students in it.
Those kids are going to make good incomes, aren't they?
So you have to be a college graduate, and then it's a 2-year program, and typically make $120,000 to $170,000 coming out of school. That's pretty good.
I'm not sure I ever made that as a lawyer.
Right. So Drury's just started that program. They've just enrolled their first students this last 2 weeks. So yeah, we need more of those programs.
Let's talk a little bit about the high cost of prescription drugs.
Yeah.
What do you have to say about that?
You know, I'm grateful for the innovation that pharmaceutical industry gives to society, and I'm deeply disappointed in how they manipulate patents. And so if you think of it, a typical patent is 7 years. And so, you know, the person who discovered insulin and made it marketable, a Canadian physician, thought it was unethical to have a patent on it. He thought that this is something that's too valuable to society. And so he never got a patent dollar for creating insulin. We have a drug that we've had to use for a patient that costs $1.4 million.
My goodness.
It's a life-saving drug that can make a 3-year-old or 2-year-old live a normal life that would otherwise probably have a life expectancy of 2 years.
Get some cured and then they're okay.
Yeah, the course of treatment is brief, but it's $1.4 million. So, there's elasticity of demand. If you're going to go to the car lot and buy a new Chevy, there's a price you're not going to spend any more for. But if it's your 3-year-old, I will give every limb of my body to save that. So elasticity of demand is a problem in healthcare because we'll pay our last dollar. Pharmaceutical companies know that. And one, there's a lot of research and development dollars, and they've got to get return on that. Once the patent is over for 7 years, then they change the formula. They tweak it and say, well, this is a long-lasting version. So instead of short-lasting, you need to take half the tablet twice a day, or whatever it may. I'm simplifying it. Then they get the clinical protocols, get the physicians to do the peer-reviewed research, et cetera. Then it becomes standard of care. And if you don't follow the standard of care, malpractice attorneys are going to come get you, right? And so physicians follow that. There are really horrible stories of drugs that maybe there were 3 manufacturers and they boiled down to 2 because the profit went away and it was only per 10 pills, it was $5. And then that company buys the last manufacturer and then they control it. And then the price goes up to $2,000.
Well, why can't some other company come in right behind them and just sell a generic?
Yeah, and that's what they can do. But that company will make their profit while they can. There's groups of hospitals now, systems, that are beginning to invest in making their own generics to try to thwart that price incentive for the pharmaceutical companies. So there's that angle. But, I've often argued unsuccessfully that if there is a tornado that goes through a town and you increase the price of gas by $1, that's price gouging. If you increase the price of insulin by tenfold, that's price gouging. It's putting people at risk. The government's not acted on those. Very rarely have they acted on that.
I'd heard that, I'm sure it varies on the drug and so forth, but a whole lot of the cost associated with the production of a drug has to do with marketing and not the actual research. To what extent is that true?
Well, you can bury marketing cost and you can inflate marketing cost. And so maybe marketing is a TV commercial to sell it, right? We see people running through fields of daisies and they're happy. We don't know why, but we'll take that drug.
Right.
But also in developing the product, you need physician support. So physicians are paid to advocate for the drug. It's a new drug that's new to the market and they need expertise. So physicians are often paid to go and represent that company and go out in the market. There is no savvier marketing expertise in pharmaceutical reps. They're the most highly trained marketers.
They're paid well.
They're paid well. And obviously, it makes sense for the pharmaceutical companies because they're making a lot of money. So yeah, there's a lot of money.
Well, isn't there some discussion about maybe government should do the primary research on developing drugs and then that would lower the costs and then let the pharmaceutical companies market?
Intuitively, that makes sense. I'm still a little young, but in my entire life, I've never seen the government do something more cost effective than private enterprise, right?
Well,
so I doubt their ability to do that.
Fair enough, fair enough. What about how long it takes to get it approved by the FDA? On balance, is that reasonable?
I think if there's a criticism, it's often that it takes too long. At the same time, so often we don't know the long-term effects of a drug, and so patience is important. I like that there are provisions made for, circumstances that are life-threatening that we can make exceptions. I'm not an absolute advocate for the FDA, but I think they balance that pretty carefully. Being safe, being cautious, versus trying to expedite something getting to market because it's got an urgent need.
You said early on in the interview that you're not a big advocate of that. Tell us what the pros and cons are of that.
Yeah. Obviously, one of the big advantages is that you can control costs better. If you have primary care access in a country, you can probably overcome some of the challenges we have with kind of focusing on this acute intervention. At the same time, access, which is a challenge in the United States, is a nightmare in other countries. So, there's reasons that U.S. cities that border Canadian cities are profiting so much from out of pocket from Canadians that don't want to wait 9 months for an MRI.
The expression is rationing healthcare.
Yeah, it's rationing. You're losing control. And in every country that has socialized medicine, there's also a private insurance arm where people want to pay because they don't want to wait. So you make real pragmatic decisions under national healthcare system, socialized. The thing that I worry about as well is they don't drive innovation. They don't drive research. And so capitalism works and it creates innovation. And so our system is the economic engine for innovation in healthcare. As I mentioned, more than half the patents come from the United States. So you don't want to give that up. Now, I think there's ways to work around that. It's working for other countries. Truman proposed national health insurance and he didn't get it right. We started with this hodgepodge quilt system where we added on to benefits in World War II, and that became the foundation of a really broken financing of healthcare. Can we switch it overnight? And there's so much economic interest, the lobby power.
A lot of stakeholders.
Yeah. Imagine the lobby power of pharmaceutical companies. We got a lot of dark money moving in politics now that's not as visible. Mm-hmm. And these guys rely on that money. These men and women rely on that. And so I think the way we do it in the United States is we transition toward that. I think we're heading toward socialized medicine. If you look at Medicare and Medicaid combined, it's more than half. So in many ways, 30 years ago, we might argue we're at socialized medicine now. But we got it there the hard way and in a way that I think is a patchwork that doesn't provide very good care for primary care.
At the end of the day, are you optimistic?
I am optimistic. And here's why. Think of the pandemic. China has an outbreak in the city of Wuhan, and about 3 weeks later, World Health Organization says this is a real problem. I think 7 days later, the DNA sequencing for the coronavirus was made available. And by middle of January, we had human trials going already.
And the original projection was going to take a much, much longer time to develop that vaccine.
Yeah, that's using kind of like the analog method, the non-mRNA method. I look at it this way. When we found the polio vaccine, the country became enlightened to the value of healthcare. We funded a Hill Burton Fund, which built almost every hospital in the United States got Hill Burton funding. That happened after polio vaccine. We have crippled children who are no longer going to have to suffer that, future children. So I am optimistic, but the process is long and there's ups and downs and there's a lot of pain to be had between now and then.
Is there anything I failed to ask you about just the general state of healthcare in the country you'd like to share?
Well, I think there's so much we can talk about healthcare, and maybe if I could just say one thing. If you look at this high altitude, there's so many problems, but I'm really grateful for the way our city leaders, our mayor, city council, helped us as healthcare providers during the pandemic. They bought us an extra month or two to get ready. And that took courage. They probably had death threats. But the difference for us and having a couple extra months meant that we had all the PPE we could need. We had the ventilators we needed. We built a 54-bed ICU in that time period. We got our staff trained. I think before, as the pandemic was coming, our projection is we could probably handle 5 to 10 patients because hospitals were always at their near capacity. And when we heard there were hospitals in Arkansas that had 25 patients, we couldn't imagine. At the height of the Delta, we have 220 patients in our system. The city council, the mayor, health department, they saved us by helping us buy time. And it's a real important balance because you've got to be mindful of your economy. When the economy goes down, people struggle. And when people struggle, their health goes down too. And so you had to balance that out. And so I'm really grateful that they took that risk to help our healthcare providers and help take care of our community.
I do think that people in elective office, we all like to throw rocks at them from time to time, but they have some of the hardest jobs. Because if you're a healthcare professional like yourself, you know what your mission is. It's to save lives.
Right.
But there are trade-offs.
Right.
And do you close down the schools?
Right.
Do you put small businesses, threaten them with closing because they can no longer be profitable? And you have to balance lots of interests. And frequently it just depends on who's shouting into which ear. But
right.
Those are tough decisions. And I would rather see those kind of decisions made by elected people. Now, I do believe that decisions should be evidence-based.
Correct.
And what's the best science and that sort of thing. But at the end of the day, a lot of this is a judgment call. You do the best you can.
That's right. Yeah. And I'll take our city's response up against almost any city because you had extreme responses. You had states that took COVID dollars and turned it into tourism budget, which made the situation worse. You had states that shut down cities entirely, shut down schools for years, and there's a balance. But that extra couple months, I think, saved thousands of lives in our area, and I'm I'm just very grateful for Ken McClure and all of our city council.
Well, and it's not the last pandemic either, is it?
No, I tell people sadly that this is a training pandemic. We got a really easy one, and we did horribly as a country. And I'll share just a couple of quick numbers on that.
Yeah.
So when you look at the ability of infectious disease to impact a community, there's two factors that are most important. One is the R0, that's a transmissibility rate, and the other is a case fatality rate. So how many people will get it from me if I get it, and then what percentage of people that get it die? So this disease has varied in its infectivity, which happens. The viruses tend to become more infectious and less deadly as they evolve. So it ranged from 1.5 to 3.5 R0, meaning if I got it, I would give it to 3.5 people.
And you got to get it below 1, don't you?
You got to get it below 1. If at 1, it's stable. Anything above 1, it's growing, right?
0.9, it will start dropping off.
Absolutely.
Yeah.
So measles is generally thought to be about an R0 of 22. So if I got measles, I would likely give it to 22 people.
My gosh, I had no idea it was that contagious.
We lost 1 million Americans, but the case fatality rate is actually very low, right? It's less than, a fraction of a percent. Ebola's case fatality rate, there's kind of two general types, probably about 67%. So if everyone gets it, 2/3 of them will die. So Ebola has a very low transmission rate. It's hard to transmit it. So just above 1, it's really kind of right at the endemic stage. Imagine if you had measles infectivity and the Ebola virus, this would be World War Z. I mean, the world would be wiped out. As a matter of fact, you probably need a case fatality rate of something around 2% with a measles rate to wipe out the Earth, except for those people that have some kind of natural immunity. So this is a trial, and
I'm going to move up my vacation.
That's a cheery note to end it on, right? Yeah. Well, the other challenge is, so a lot of viruses skip from one species to another, and that's how we get them, right? And we never had this. We have these giant mega cities in third world countries now, and they're bordering jungles and forests and eating into those, and so the risk of zoonotic transfer is much higher and growing higher. So unfortunately, I think we have to take these lessons and learn from them. I think we need to help elected policy officials work on it. One of the challenges of the United States, we have 5,000 independent health departments, and they don't work in coordination. And so if you're in the United Kingdom, if the health minister says we're going to do this, they all do that. And so that's another challenge, just the way we're structured. You can have
federalism, right?
It is, yeah. And so we've grown as a United States, not the federal, and that's part of our culture. But in the next pandemic, we can't have 5,000 health departments acting 5,000 different ways.
Well, on that note, I want to thank you first for your service to this community, and then secondly for being our guest today on In Our Town.
It's an absolute honor. Thank you, Mayor.
That's it for this week, and many thanks for listening. If you'd like to listen to other episodes, you can visit the Springfield Daily Citizen website at sgfcitizen.org/In Our Town, or subscribe wherever you get your podcasts.